Hi, my name is Kent Van Sickle. I'm a professor of surgery and a faculty member at UT Health San Antonio. I've been a faculty member here for almost 13 years, and I'm the division chief for general and minimally invasive surgery. My clinical interests are in bariatric surgery, weight loss, to include primary weight loss surgery and revisions of prior weight loss operations. I also take care of complex upper GI and foregut conditions such as reflux and paraesophageal hernias, as well as hernias of the abdominal wall. I am also the medical director for the UT Health Weight Loss Center. So a revision is an operation that refers to someone who's already had a prior weight loss surgery, such as a sleeve or a bypass or even a lap band, or even an older operation done some 20, 30 years ago that has for some reason failed and has caused the patient to seek further treatment. So weight regain by itself is not an indication to have a revision necessarily. You also need to have some other medical problem related to your prior operation, such as stenosis or a stricture of your sleeve or bypass pouch. Weight regain is a possible consideration for revision, but it's not exclusively. You can also have other problems like chronic heartburn or reflux from a prior operation, such as a band or a sleeve, that might justify the indication to get a revision. Or patients who had an operation done many years ago, 20, 30 years ago, where the staple lines that were done at the time of that surgery have now broken down, and that has caused patients to regain weight or have regained symptoms or even medical conditions such as their diabetes. Those patients would be eligible for revision. Weight loss following revision surgery is comparable or similar to the amount of weight loss seen in the primary bariatric operation. Most patients that are undergoing revisions tend to be not as obese because they're getting revisions for other indications. So the total weight loss may not be identical, but they're very close and similar in how they lose weight. Usually much more weight is lost in the first 6 months, and usually the plateau of weight loss is within the first 12 to 18 months. So generally speaking, patients who undergo revision are at slightly higher risk for complications than patients who have never had a prior operation. The reason for that is that we're going back into an area that was previously operated on, and so there can be things such as scar tissue and foreign bodies that were there from prior staple lines and suture materials that can increase the risk of surgery. The good news is the risks remain low, usually in the single digits, 3 to 5% range for things like bleeding, surgical site infection, or technical issues related to the operation. As a general rule, patients undergoing revision are likely to stay in the hospital slightly longer than those undergoing a primary weight loss operation, but the length of stay is still very reasonable, certainly less than a week, somewhere in the 3 to 5 day range. Hernias are very common. They present as a bulge in the abdominal wall, either from a prior operation or just occurring naturally. But patients who are obese, typically with BMIs greater than 40, are not good candidates for hernia repair because the obesity predisposes that operation to fail. So in cases where we have morbidly obese patients with large hernias, we can provide treatment for those patients with a staged approach, where we typically perform a weight loss operation first, and then the patient loses the sufficient amount of weight, and we go back at some point later, usually 6 to 12 months later, to perform a definitive hernia repair. So it can be done.